This episode of EMS One-Stop is brought to you by Lexipol, the experts in policy, training, wellness support and grants assistance for first responders and government leaders. To learn more, visit lexipol.com. That's lexipol.com. Hello and welcome back to another edition of EMS One-Stop. I'm your host, Rob Lawrence, and a few weeks ago, I was over on the other channel with Chris Cebollero inside EMS. I was talking about politics and politicking, and no sooner had I finished recording that I switch on to the congressional channels, because what else do you watch when you're not doing podcasts? And there we were with the Congressional Ways and Means Committee, and none other than our great friends, Dr. Ed Racht and Matt Zavadsky, were giving evidence, not on Capitol Hill, but in a hangar somewhere in deepest, darkest Texas. And so to talk about that and to talk about actually the implications of their evidence, their statements, I'd like to welcome Dr. Ed Racht and Matt Zavadsky. How are you, gentlemen?
We're well. How are you, Rob?
I am good. It's bright and early here on the left coast of the United States of America, and so looking forward to this chat. So you both were giving evidence at the Ways and Means Committee, a congressional committee, and we have to just acknowledge the fact that Randy Strozik, the president of the American Ambulance Association and also fellow GMR leader, had previously given evidence at the Ways and Means Committee. So we're getting noticed up there. But first question first. What is the Ways and Means Committee?
So the Ways and Means Committee in the House is probably one of the most powerful committees in Congress because it controls the purse strings. Anything that has any substantive impact on the federal budget, those types of things, has to at least go through the Ways and Means Committee. But interestingly, for years, the Ways and Means Committee has been very engaged in the EMS issues because of the impact on the overall cost of healthcare delivery. So the AAA, NAEMT, GMR, a number of organizations have been engaged with the Ways and Means Committee for a long time, at least the staffers of the committee. Great group of folks.
And you know, Rob, just as a side note, you mentioned it, but I think it's so important that we are being noticed. And I think one of the, as Matt just described, all of us and probably everyone listening to this podcast knows that EMS is a practice of medicine, knows how important EMS is in that overall patient encounter. Yet when you look at sustainability and funding and all the things that are just miserable to try and focus on the EMS practice of medicine, and we don't spend a lot of time there. So the fact that they are interested, and I mean, you all correct me if I'm wrong, but I think sincerely interested. I think the questions were spot on. I think the interest in understanding this, and maybe most importantly, the interest in understanding the risk of not funding and sustaining this out-of-hospital practice of medicine, I think it's getting notice.
Wonderful. Well, in a second, we're going to play both of your evidence sessions. But obviously, talking about that, you don't just turn up and talk off the cuff. There's a lot of preparation and a lot of things you have to do in order to get there. And I know that both of your organizations had published the statements that you inevitably read. And so just before we get to the actual hearing itself, just talk about the lead up and the preparation that you have to do in order just to get there.
Our navigation of this, or the introduction, came through Missouri, right? So the chairman of the Ways and Means Committee is from Missouri, and Jason White and Justin and a bunch of folks from Missouri had been engaged with his office, and the office staff had asked a lot about treat no transport, mobile integrated healthcare, community paramedicine. So they referred them over to me, and we had a probably 90-minute scheduled for 45, but they had a conversation for 90 minutes, getting the background. How does it work? What's the evidence? What are the models? And that was just a regular conversation. And it wasn't until the next day when they said, we're going to be doing this field hearing at AMR's headquarters in Dallas. Now, they said Dallas. Thankfully, it wasn't in Dallas. It was in Denton, thank goodness, because I try not to go to Dallas, being from Fort Worth. But then it was this long, drawn out,
They meet him at the city limits. They say, Zavadsky, we're not letting you back in.
Back in, yeah. But you literally, you write your testimony, they vet it. Then literally you have to sign a stack of information, or sign a bunch of waivers. And I don't want to say it's scripted, but the testimony, they know it's coming because it's pre-printed ahead of time. I had to correct Ed's quite a bit because his was written in crayon and it was a little hard to read, but no, it's very well orchestrated and very well done.
So
Yeah,
the
I
other bit you mentioned
Testimony.
there, though, is that you didn't have to go to DC. You weren't on Capitol Hill. It was a field trip. And actually, it was in your location, Ed. So, I mean, how did that come about?
So I think, again, I'll echo what Matt said. This was a very well organized, and look, my initial sense of this is, here we go, gonna jump through hoops. We go through the interview process, but I do believe they truly, same experience Matt had in my discussions with staff prior to the event. They wanted to know, what are the issues, what are the challenges, what are the things we need to direct our electeds at to better understand what's going on. And I think they did a really nice job of doing exactly that and asking the questions that are tough questions. Our representative, we went through the Texas side, and our representative was instrumental in working with our organization to find a field trip that actually had stuff you could touch. So our hangar in Denton, we were able to put ambulances, real live pilots, real live aircraft, real live flight folks, paramedics, EMTs, so they could ask questions. And again, I was pleasantly surprised with their level of poking around, the field day, putting their head inside an aircraft and saying, gosh, how do you take care of someone who's really sick in there? And to be able to say, exactly, that's exactly one of the challenges. And understanding from the folks that do it every day what some of the issues are out there.
Great. And it was obviously a very powerful backdrop. It wasn't, that I'm going to use a clinical term by not being clinical. It wasn't as clinical as being in a hearing room in the national capital. The image was very, very powerful, and you could see, and folk in a second will see, I've got the video coming up with some stills of the day, if you like, how impactful that hearing was, apart from the fact you left the hangar door open and people started to get cold, but we won't go there.
It was Texas in the end of March, and there was a point in there where it was freezing. There was a beautiful gust. Several of the representatives had their staff start bringing them little blankets and shawls. So we figured that what a great opportunity to show them the power of prevention in emergency medical services. So Matt, how many lives did we save just by closing the hangar doors?
Easily 18 or 20, and that doesn't include the audience. So yeah.
I would like to congratulate you, because you're now enshrined in the Library of Congress as the hearing went into recess to, quote, close the hangar doors. So there's probably a first. Anyway, let's just pause here and just take a second, actually a few minutes now, to watch back your actual testimonies to the Ways and Means Committee. And you both make excellent points, and we'll just view it, and then we'll come back and talk about some of the issues that you raised.
Thank you. Good afternoon, Chairman Smith, members of the committee. A special thanks to the Congresswoman for allowing us to meet here at our hangar with our representatives and being in this beautiful space. Having us serve as host for the venue is very, very much an honor for GMR. My name is Dr. Ed Racht. I'm an emergency physician. I'm the Chief Medical Officer of Global Medical Response in GMR Medicine. I have the privilege of working with 36,000 other folks who are at work right now, out saving lives throughout the country. And we respond to about 5 million patients a year in all 50 states. As you can see, one of the components of GMR is being able to be ready to take care of patients, as you've just heard Chloe talk about. I appreciate being a part of this discussion in the growing challenges in EMS as we face caring for acutely ill and injured patients in urban, rural, and frontier communities. Emergency medicine combines the science of healthcare with the logistics of getting to that patient's side and getting that patient to the appropriate level of care in the appropriate community in a timely fashion. And I want to give you some good news. The good news is over the past 2 decades, emergency medicine, and congratulations, as you've heard, has done a very good job of refining the science and the delivery of our care to be able to manage patients. We've made tremendous strides in being able to decrease morbidity and mortality from out-of-hospital acute illness and injury. It wasn't that long ago that patients who suffered from a stroke were destined for long-term care or permanent disability. It wasn't that long ago that patients who had a myocardial infarction or a heart attack would have permanent disability, and the myocardium, the heart, wouldn't get back to normal function, so they'd live a disabled life. It wasn't that long ago that patients who were acutely injured, blunt trauma and penetrating trauma outside the hospital, didn't have a chance to survive and live a normal life as they do today. And it wasn't that long ago that individuals like Chloe, individuals that the world saw in Damar Hamlin, who suffered an out-of-hospital cardiac arrest, the team came together, were able to resuscitate them and get them back to a normal life. So the good news is the EMS professionals, the emergency care professionals, have done a very good job of advancing the science and the art of that science to deliver that level of care. Our EMS system, thanks to the committed professionals, to research, to technology and deployment, has never been this effective at clinically changing life and death situations in the out-of-hospital environment. But remember, these events occur 24 hours a day, 7 days a week, whether it's rain, a beautiful day like today, and where it is, how remote it may be from a facility, it may not be near the appropriate facility, these events still occur. So an important part of EMS is being able to anticipate, prepare for, and predict where those emergencies may occur so that we can be in the right spot. That cost of readiness is extraordinary. You have a chance to see that today. To be prepared, the men and women that staff these helicopters, these ambulances, have to be up on the science, the skill, and the art of delivering care to their patients. Our mission in EMS is to manage an acute event whenever and wherever it occurs. Our mission statement at GMR is caring for the world at a moment's notice. I have to tell you, I love that phrase because it says when something happens, we're in there to be able to help the individual get back to normal life. To fulfill that mission, we need that 24/7 readiness and the ability to respond around the clock. The infrastructure and the teamwork is an important part of making sure we are prepared. You've seen the aircraft, you've seen the ambulances. These are mobile ICUs today with the technology to be able to stabilize and treat patients in the out-of-hospital setting. So how we maintain that workforce is an important component during the post-COVID time period. We've struggled with recruiting, we struggled with retention, and many critical access hospitals have closed their doors. So we're trying to maintain that in a difficult time period. We are the front of the front line in medicine. We struggle with all those challenges, and to remain sustainable in the environment, our ambulances and clinicians are that link to life-saving care. We struggle for the response in implementing the principles of the No Surprises Act and being able to create sustainable funding for what we do. One of my colleagues, Flight Nurse Carmen Hicks from Greenville, Texas, is in the room. She responds to these folks, just completed her 500th flight out of a community of 700. She has 200 more to go. She and her colleagues have stories of taking extremely difficult, acutely injured and ill patients and giving them a chance. So we need your help. We need your help to continue to provide care for these life and death circumstances. We need you to help us strengthen the safety net, and all of us in emergency care, all of us in the entire spectrum, thank you for paying attention to this critical issue.
Thank you. Good afternoon. Thank you, Chairman Smith and the House Ways and Means Committee for inviting me to testify at this field hearing, examining the challenges and opportunities surrounding recent events and investments in emergency care and how to strengthen access to emergency care in America. My name is Matt Zavadsky, and I am the Chief Transformation Officer for the Metropolitan Area EMS Authority, which is the public utility model EMS agency for the city of Fort Worth here in the great state of Texas, and 13 other municipalities that are part of the EMS Authority. We're also known as MedStar Mobile Healthcare. I'm also the South Central Regional Director and past president of the National Association of Emergency Medical Technicians, and still work field shifts on an ambulance at MedStar as an EMT. I've been an EMS provider for the past 44 years. It was at a time I could begin serving as an EMT at the age of 7, in case you are doing the math, and learned early in my career that a lot of patients who call 911 for EMS do not need to be treated in an emergency department. But CMS payment policy is such that we are incentivized to force every patient to be transported to the emergency room, because that is the only way that we are paid by CMS, is if we transport someone to the hospital. Having the opportunity to advocate for the improvement of EMS models and payments in Texas is an honor. Ambulance services are a vital component of our local and national healthcare and emergency response systems, and serve as lifelines of care for a wide range of individuals, including seniors who rely on Medicare, especially in urban, rural, and in super rural settings. Thankfully, innovative EMS agencies such as MedStar, Global Medical Response, Dallas Fire Department, and others have initiated patient-centric programs designed to prevent 911 calls, and even when 911 is called, appropriately navigate patients to the most appropriate care setting. In 2009, MedStar was one of the nation's first mobile integrated healthcare community paramedic programs in the country. One of our programs is a high utilizer group patients, or a high utilizer group program. Most of those patients just need hugs. Designed to help frequent 911 callers learn how to better manage their health conditions and connect them to community resources. Since 2013, 22,000 patients have been enrolled in this program, and those patients have reduced their 911 use by 51.2%. They've enhanced their perception of care status by 27%, and reduced their healthcare expenditures relating to ambulance, emergency department, and inpatient care by over $20 million. But yet we have not been paid by Medicare for one of those patients because it's not a covered service. On the 911 side, we have been working with Congress to sponsor legislation to provide EMS the flexibility to navigate patients to the right care at the right time and in the right setting through treatment in place programs. Currently, the EMS economic model incentivizes transport to an ER, since treatment in place is not a covered benefit and we don't get reimbursed for that service. A recent study by RAND published in Health Affairs found that 15% of Medicare patients brought by ambulance to the ER could be effectively treated in an alternate setting, and that would save the Medicare program over $550 million annually. Ambulance services across the nation, especially in rural areas, are facing unprecedented challenges, as you heard Dr. Racht talk about. The pandemic further strained our workforce, placed significant new demands on our services, and has generated enormous competition for healthcare personnel. Medicare currently provides temporary 2% urban, 3% rural, and super rural add-on payments for ambulance services. These add-on payments are essential for ensuring access for all patients for vital emergency and non-emergency care, but they still do not bring payment rates up to the level that covers the cost of providing the service. Years of below-cost Medicare reimbursement have hampered efforts by ambulance services to hire, update equipment, and continue to provide life-saving services in their local communities. Ambulance services have closed their doors or been forced to lengthen response times because of the stresses on their systems. These payments, these add-on payments, expire at the end of this year. Ground ambulance services are currently providing their revenue and cost data to CMS, which will help Congress determine how much to reform the Medicare ambulance fee schedule. However, reform is likely several years away, and ground ambulance service organizations cannot wait that long for additional relief. Extending the Medicare add-on payments is essential to ensure access for all patients for vital emergency and non-emergency care. Again, thank you for the opportunity to testify on the challenges and opportunities for EMS to ensure accessibility and quality care to our patients in Texas and the nation. I look forward to continuing to work with you and your committee.
Thank you all, and it wasn't without the usual Zavadsky humor, and of course sometimes Matt, that actually works and it gets through to people, and we realize that it makes people pay attention. So thank you. We won't talk about the names. I'll come on to that in a minute, because there's clearly some issues about how we select people to go and give evidence. But now that you've watched it back, and obviously you've probably done it a couple of times, what were your sort of initial impressions of the impact of the comments that you made on those people sitting in front of you?
You often look at little clues from people. And one of the things that I noticed throughout the entire hearing is that when not only Dr. Rocket, myself, others were talking, folks were taking notes, and they were literally paying attention. Now, it could have been because they were in front of ambulances, they were in a hangar, they had air ambulances in front of them, and they were on television. But the questions they asked, and they prepared questions. They did a good job preparing questions. And I think more than anything else, it was the follow-up. After the hearing was over, there were half a dozen of the legislators that came up to Dr. Rock and myself, literally wanting more information. How do I get? And the staff were all over us. Hey, when are you going to be in DC? We really want to get this pushed through. So I think more than anything else, they understand the issues because they were very articulate. They were articulated very, very well. But I think more importantly, they understand the finance. These are finance people, and they really understand the financial implications of some of the issues that we're facing.
Actually, the timing for this, and particularly when this podcast comes out, Matt and Ed, is, of course, we're on the eve of NEMT's EMS on the Hill. So is there an opportunity then to go and drive this home, to use this podcast, which contains the hearing, and actually take it to the folk on the Hill?
I do, because the providers that are going to hear this podcast are going to get these messages, and they're going to be able to be more comfortable talking with members of Congress about the legislative agenda that we need as a profession to be able to survive.
I agree. And I think one of the things that I really loved about this field hearing was we were all united. The EMS, the front, whether it was GMR, MedTrans, a hangar, air, fixed wing, ground, MedStar, the entire our cadre of the EMS family was all united, and we were united to say, here, 24/7, 365, we got you. We got you. And it's harder than ever for us to take care of our community, staffing challenges, all the issues we face on a day-to-day basis, but we continue to move forward. When we unite as EMS across the board and send a consistent message, we are the front of the front line. And I think the power of EMS on the Hill on top of this, and continued information and unified information about where we need to be, is really our opportunity to say, you got to pay attention to EMS medicine, what we do, the safety net, because we love doing it, but we need help to continue to do what we're doing.
You just issued a spoiler alert to my next line, because I'd actually highlighted the fact you just said it, and you said it in the hearing. We are the front of the front line in medicine. That's an Ed Rock quote. I'm going to be using that, possibly hashtagging it very soon. Absolutely right. And everybody hunting as a pack, legislating together. When we get to EMS on the Hill, I have no doubt we'll see every other association there representing themselves as well. So that's an important bit, to realize that everyone's in this together, forcing forward. Some of the things that you particularly said, Ed, I was very impressed how you were, you laid out the lot of EMS, the fact that we are the front of the front line, the fact that we are there, the fact that we are delivering care, but the level of reimbursement is just not following that. And I think you initially laid that out very elegantly.
Yeah, and I appreciate that. Now I got to figure out what the lot of things is. It's like the lot. I guess it's a lot. So No, I appreciate the recognition that we, as an organization, look, you have to love EMS the majority of the time. Now, there are days that even those of us who love it hate it, but you've got to love it to do it. It's arguably one of the hardest components of medicine, period. Right after an event occurs, often devastating events, unplanned, not in an office, not in a hospital, not with support staff. And literally, it's a cliche, but if you look at the profession that looks life and death right in the face, that's our profession. And we have the ability to really shift that balance to life and to a better quality of life. And this is our opportunity to continue to send that message. We're a cool family. EMS is a cool family.
And we do cool things. Our good friend in the UK, Dr. Linda Dykes, always says, at the point that we see the patient is unselected. In other words, we can't just snap a finger and say, cardiology come down, surgery come down. We're it. We're there. We're doing it. And, that's a great analogy. And thank you, Linda. Before we go any further, we're just going to stop for a quick message from our sponsor.
Lexipol empowers first responders and public servants to best meet the needs of their residents safely and responsibly. Serving more than 2 million public safety and government professionals in over 8,000 agencies and municipalities, Lexipol offers a range of solutions that includes policies, training, behavioral health resources, news and analysis, and grant assistance services for law enforcement, fire and rescue, EMS, local government, and other agencies dedicated to public safety. To learn more, visit lexipol.com. That's LEXIPOL.com.
Dr. Rocket, you are now recognized. Thank you, sir. Mr. Zavadsky?
Matt's fine.
Matt,
we'll get there.
You're now recognized.
And we're back. And as you heard there, that we couldn't get the names of Dr. Rocket and Mr. Zavadsky right for any of the hearing. And based on that, Matt, you've got an interesting backdrop today to share with us. I'm not a Marvel, whatever it is, of the universe fan. So who's your backdrop?
Hang on one second, Rob. I've asked some of my HR colleagues to come in and witness this. We need to document it so that Matt can get into the right class. So
because of Dr. Rock's very unique spelling of his name, many of the members of the committee really overemphasized the T at the end of Ed's name and started calling him Dr. Rocket. So, of course, I promulgated that, and I used him as an example of treatment in place, I believe, and referred to him as Dr. Rocket. Now, this character, for those of you who might be half the age of Rob and myself, is, in fact, Rocket from Guardians of the Galaxy. So I figured it was appropriate to have Rocket join us for this podcast, for this vidcast, sorry.
So before we go on, don't forget, everybody, please make sure that you like and subscribe. If you're watching us on whatever platform that you're either watching or listening to us on, make sure you hit the little check mark, the little plus mark, and every time an episode of EMS One-Stop drops, then you'll get notified. Also, if you're listening to us, don't forget you can now watch everything on the EMS One YouTube channel. So not only do you get to see our handsome, well, apart from Matt, smiling faces, but also we're included the images, charts, graphs, etc., to give a little bit of extra zhuzh in order for you to enjoy our conversation. And obviously, in this particular edition, if you're listening to us, switch over to YouTube and you can see Matt and Ed giving evidence in the hangar, in the cold, but making some amazing points. So make sure that you do that. So, of course, I'm talking to Ed and Matt. We're talking about the Ways and Means hearing. And Matt, I just want to sort of pick up because, of course, your initial statement, Ed did that sort of amazing opening job. We've known for a long time, Matt, you are the stats, you are the industrial memory of EMS, and obviously you're able to give some great statistics and some great points that you made. But when you were setting out to write your statement and to give your evidence, what was the key thing that you wanted to bring home to them?
Well, I know that House Ways and Means looks at money. And let's face it, we've told CMS this, it's no surprise. And all of us know Medicare payment policy drives clinical practice. Even though CMS might not like to admit it, it does, both for the good and the bad. So if we can paint the picture for the Ways and Means Committee that things like mobile integrated healthcare and treatment in place and even aeromedical transport to a higher level of care downstream saves money, that's going to sell this initiative with the Ways and Means Committee and arguably the rest of Congress. So working with a number of different providers and NAEMT, we used AHRQ, the Agency for Healthcare Research and Quality, payment data for ER visits and CMS's waiver for treatment in place during the pandemic, and did a financial analysis and said, if you pass a law that no longer incentivizes us to spend Medicare's money, here's what it could mean in terms of savings to the healthcare system. And the staff from Ways and Means and even Chairman Smith wanted to make sure that that information came out, because that's the information EMS, if we get more funding to be able to do patient navigation, the downstream savings is almost a 200% return on investment. And that's the things that will get that bill passed.
Excellent. Thank you for that. And interestingly, once you got past your statements, of course, there was the kind of free flow questions. And I thought that they asked some very intelligent questions. And of course, the answers were equally as compelling. One of the things that have been challenging us in the pre-hospital scenario is actually when we have to send the bill, of course, now through balance billing, there is, the patient, thankfully, in many states has been taken out of the middle of it, particularly here in California. And I think 16 states now have balance billing legislation, which is a step in the right direction, because eventually when we have a federal balance bill rule on ambulance services, they will defer to state level legislation. So it's all heading in the right direction. But of course, one of the issues we're having is the appeals process that we go through. And Ed, one of the questions that they'd asked you is about the challenges and the complications of the appeals process. And so there's no money anyway, but we're not getting paid either. So, I mean, explain your discussion around the appeals issues.
Yeah, and I think, one of the good sides of the No Surprises Act is it did exactly what I think everyone listening to this podcast and all of us would agree on. Take the patient. They've got enough of a challenge with their unplanned, often very scary, significant event. Take them out of the process. And that's one of the main principles behind the No Surprises Act. One of the challenges in implementing that is there is a process called independent dispute resolution, which makes very good sense. It means, just like in marriage counseling and anywhere else, there's a difference. Two individuals knowledgeable, or two entities knowledgeable, sit, make their case for why this is should or should not be reimbursed by the payer, and then a decision comes out of that. One of the challenges with the IDR process is it removes medical necessity. So one of the things that I think arguably is the most common cause that we should look at, the reasons, Rob, that you just described, or Matt, this ability to get a patient from point A to point B, the importance of moving an evolving myocardial infarction from a small rural hospital, maybe hopscotching a couple other facilities to get them to the cath lab, or to get them to the trauma center, or to revascularize their stroke. We take that for granted in medicine, and it makes a huge difference in outcome. Underline, huge difference in outcome. But those medical necessity questions are excluded from the IDR. So it takes away our ability to sit with our colleagues on the payer side and say, we disagree, and here's why we disagree. And by the way, this is the piece that's most important to the patient that received that level of care.
So having said that, and the fact that, of course, we are going through the IDR process, I just saw an article from you, Matt, where, of course, CMS, we are a drop in the bucket in terms of, the spend, but it seems to be going well elsewhere, Matt.
Interestingly, the process of the IDR is not going well. and CMS has even admitted it. That was one of the questions that came from the committee members. CMS is constant. It's on again. It's off again. We're suspending it. We're refining it. We're going to put it back in place. It logistically and procedurally has been very challenging. However, the outcomes from the IDRs, according to an article that was in Axios yesterday, the data has actually shown that the providers are making out really well. So for those providers that are able to navigate the difficulty of getting the IDR done, pay for the process to get the independent dispute resolution through to the end, they're getting reimbursed much higher. So one of the things that many of us had thought maybe this might do for the healthcare profession, not just EMS, but for all of healthcare, is it will finally shed some light on the payment practices by some of the payers. And after 5, 8, 10, 20, 200 lost IDRs, and the payers are starting to have to, we're having to increase payment. Hopefully, fingers crossed, the payers will just stop fighting it and say, listen, every time we're going into independent dispute resolution, where the hearing officer is finding against us and they're making us pay what the charges were, then let's just stop and we'll just pay the charges and there you go. That was one of the things we thought might happen over time, and it looks like that might be starting to happen because of the results. Now, many of the IDRs fall out because providers just give up and all sorts, but for those are the ones that, according to the article, the ones that go through to the end, the provider is getting reimbursed much higher because that independent person is looking at the insurance companies and saying, really, this is what you were going to pay?
And to Matt's point, our own experience in my day job, greater than 90% of our IDRs are found in favor of the organization. So a really good point, Matt. If you've got this independent entity that's looking at the disagreement between the two and the numbers are that high, it sends a message about the process.
And Rob and Ed, when you talk about the alignment of the stars, so you've got some experience from IDR, you've got states passing balance billing legislation, you've got the Balance Billing Commission now getting ready to release its 18.5 recommendations, almost all of which are insurers should just pay bill charges under certain circumstances. That may be the groundswell of support. That might be the tipping point so that Congress will say, okay, looking at all three of these different factors, states are implementing, you pay bill charges. Most of the time, the payers aren't really fighting that because EMS is such a small spend. And you've got that recommendation coming from the Gap Back Committee. Federal legislation could be very favorable towards EMS and certainly the patient by doing what many of the states have done and said, hey, if the agency publishes its rates, you pay those rates, period.
And actually, that is the basis of the balance billing legislation here in California, that it is set in now in a tablet of stone that if the local governing body, the local authority have electedly have put through a rate, then that's the rate that you pay. Because how do we get to that rate? Well, we went through an RFP process where we had to show math, show the working, show the spreadsheets, demonstrate this is how much it costs to do our business. And therefore, quite sensibly, it was voted through. So that's kind of where we are. I want to get on to the next steps, but actually one of the things that was interesting to me is that the next Ways and Means Committee hearing in the series back on Capitol Hill was with Secretary Becerra. And before I ask you the question, I'd noticed that just to sort of close off the IDR question, that I actually listened to the 3.5 hours of Secretary Becerra's evidence and the discussion there. And the IDR came in for some scrutiny on the Hill, and actually the sort of nod that why are you all leaning towards the payer? I'll leave it there because that was actually made as a statement on the subsequent hearing. Now, go back to the hangar. One of the questions they asked you was, we're about to see Secretary Becerra, we're about to summon him to the Hill. What questions would you like to ask him? So what questions did you want to ask him?
Ed, do you want to go first?
Sure. So my question would be, how do we fix exactly what we just talked about, the IDR process? Because when the process is allowed to move forward, it appears that it's looking at those things that are important to the patient, important to the system to be able to sustain its ability to take care of that patient population, and it's fair. But by excluding medical necessity, we don't have an opportunity to do that. On the back end, The challenge is when the process deems that it is appropriate to pay, we're seeing sometimes upwards of almost a year that the insurance company doesn't pay us. And well, some folks would say, oh gosh, why? That's the finance of health. Come on, that's the finance of healthcare. I look at that, and over my career, and Matt, you've taught me a lot about this. You look at that and say, that's what allows us to be ready at 2:38 in the morning. That's what allows us to respond to the bridge in Baltimore and manage a sudden catastrophic event that gives us readiness, that lets us recruit into our profession to have the right people to take care of those folks. So yeah, I'd ask the secretary, how do you fix the process that you agreed on to look at the issues that now seem to be favoring exactly what we've been talking about?
Sad but true, isn't it, that the Baltimore Bridge is, I hate to use this word in this context, but the perfect example of the cost of readiness and being there, being ready to deploy.
And I don't know, total side note here, and you can cut it out if you need to. I don't know if you've listened to the initial radio traffic for Baltimore Fire and the emergency responders there. Everyone in our profession should listen to that initial radio traffic when it was initially went out as a car into the water and then evolved to the catastrophic event. We do that every day, but when you hear it and you hear the tone and the voice, you can feel what they went through.
As we come to the end, obviously you've given evidence. We mentioned that Randy Strozik had been up on the Hill giving evidence. We are clearly on the radar. We are, at the table and not just on the menu, which is good. But where do we go from here?
We have to keep the heat on. And the heat on is from the people in the field that are dealing with this every day and really painting the picture that changing how EMS is reimbursed for the services that we provide checks every box that's ailing EMS today. It infuses additional resources into the system because you're getting paid for things that you hadn't been paid for before. You reduce the downstream expenditures. You improve the patient's experience of care because you're not taking that low acuity hangnail to the ER where they're going to sit for 6 or 8 hours. You're, in many cases, giving EMS resources back to the community because they're not having to transport an hour and a half in rural areas. They're not having to sit in an ER staffing the emergency room with their patient on the stretcher waiting for an available bed. Everybody wins, and we have to keep explaining to Congress because this does need to be a legislative fix. CMS has said quietly several times, we would love to pay for non-transport, but we can't. Just like when we were trying to do it through the pandemic, we need legislative language to allow us to put in rules that pay for non-transport. Well, let's make that legislative language. There are 2 bills in Congress now, and now Ways and Means Committee can literally have those hearings on those bills, pass them out of their committee, get them to the floor and get them voted on. And now we'll be making huge change because just by changing that payment model without a lot of strings attached, now you allow medical directors like Ed and medical directors all across the country with agency leaders to figure out what's the clinical implementation of this financial model without dictating from DC or from somewhere else the clinical practice to be eligible for that reimbursement. So we just need to continue to educate members of Congress. Don't let it die. Use the EMS caucus. Use those folks that understand it to keep pushing this and get it through pretty quickly, or more systems are going to close. More systems are going to have to completely change how they do things if they need public funding. People aren't going to come to our profession, and we're just going to keep circling the drain.
Excellent. Thank you for that. So classic Rob ending question. Is there anything I've forgotten to ask or anything that you need to tell me?
So one of the things, Rob, I would add here, and Matt, you're so spot on about keeping the heat on because we have their attention. I felt it in that hangar. And look, truth be told, I didn't think I would, but I felt their interest. I saw it. I watched when you were talking about mobile integrated health and treatment in place and the ability of our profession as we're in this hangar with aircraft and ambulances to say, we're going to take care of the low acuity chronic condition side, and we can improve the experience in the healthcare system. They paid attention. And there were a couple of I've never thought about that before. So I absolutely agree with keeping the heat on, but I'd plead with our profession, whether you're fire, private, volunteer, career, urban, rural, frontier, air, ground, earth, wind, and fire, whatever you are, if you take care of patients in the EMS system, this is a platinum opportunity for us to become one. We're finally getting to that stage where we can say, put all the uniforms up there, bring the people in scrubs, bring everybody that contributes to this patient population to say, we are all united and we agree that you need to help us do what we do best. One of the things, two things that I would say are interesting. Matt, I'm kind of a creepy guy in this way. I watched before and after the hearing. We were in that small little room with all the representatives. I watched how you went up to representatives, but more importantly, how many came up to you, shook your hand, and talked to you for 2, 3, or 4 minutes, but they were interested. You knew them. You had the connection. Afterward, they came up to you and asked you questions and sought out answers. The other thing that I would point out is during my discussions with staff and briefings, one of the things they brought up often was, do you have examples from your colleagues, your care providers, about what a huge difference EMS makes? That's why having paramedics, EMTs, flight crews in that environment to say, we're the ones at 2:38 in the morning that make all the magic happen and change people's lives, they're very interested in that. So if you're watching a podcast like this going, it's one of those funding government podcasts, I hope you know and hear that this group that helps to keep us sustainable wants to hear from you about your day-to-day stuff and how you do make a huge difference in people's lives, whether you're planning for it, whether at 1:30 in the morning and you get that initial tone for a car over a bridge in Baltimore, whatever it is, they're paying attention. So when we unify, we're unstoppable in a good way, in the words of the lyrical bard, you're not the man they think you are at home. You are indeed our rocket man. So thank you for that. Matt, final thoughts.
Rocket Man, Dr. Rocket. That was perfect, Rob. I can't add anything. Great job.
Excellent. Well, and to Ed's point, that I think pre-pandemic or BC, before COVID, as Matt and I like to say, that if we started talking about EMS funding, the rank and file would go, oh, here they go again.
It's better than general anesthesia. I don't know
this is now vital to our survival, and you guys are fighting the battle. We've got NEMT on the Hill coming up, where, to your point, Ed, we're going to put uniforms in front of elected officials in their domain, and that's vitally important. But also, everybody out there watching and listening, you are the great politician. You are the great advocate. You are the great means to convey our message that we need to change, because ultimately, if we're not funded, we can't, do those pay increases. We can't deliver better levels of service. And so it all comes down to you. This is actually a call to action. But for the minute, Dr. Ed Rocket and my good mate, Matt Zavadsky, thank you so much for joining us.
It's not it's Zovar. I'm sorry, Matt. Zavadsky.
It's Matt.
Yeah, then that was the best bit. Just call me Matt. So call me Matt and Dr. Rocket. Thank you so much for joining us. And we will see you out there lobbying, advocating, and promoting our profession sometime soon. Anyway, that's it. That's been another edition of EMS One-Stop. Thank you to my guests, Ed and Matt. And you can invent your own last names for them. But for the moment, I've been Rob Lawrence. And until next time, bye for now.